Hello, this is Karl Migally, a pediatric cardiologist and cardiac intensivist at Lurie Children's Hospital in Chicago. Today we're going to be talking about low cardiac output in the CVICU, bedside assessment of cardiac output. There are no relevant disclosures. So to talk about low cardiac output in the CVICU, we need to know what is cardiac output and specifically what is oxygen delivery. And then what is low cardiac output and distinguishing that from something called the low cardiac output syndrome and from shock. And what is the bedside assessment of cardiac output by non-invasive and invasive modalities and using cardiac diagnostics, and very briefly touching on the management. What is cardiac output? I like to think of this in three facets. There's the physics part of it, which is a volumetric flow rate denoted as Q of the heart's pumping output, and the unit for this is liters per minute. The mathematical equation, as we all know, is heart rate times stroke volume, and we see how those units cancel each other out to give, again, liters per minute as the final unit. And most importantly is the physiologic element, which is that cardiac output is a key component of the body's ability to provide sufficient perfusion of oxygenated blood to tissues to meet metabolic demands and to maintain organ function. In other words, it is a key component of oxygen delivery. The pathophysiologic correlate of this is shock, and shock is impaired oxygen delivery, which can include impaired cardiac output, but is not limited to that, as we'll see later. What are the components of oxygen delivery? We already talked about one of them being cardiac output, the other being arterial oxygen content, and the product of those is oxygen delivery. Now, arterial oxygen content is also dependent on the product of hemoglobin concentration and oxygen saturation, and cardiac output, as we discussed, is stroke volume times heart rate, and stroke volume is dependent on preload, contractility, and afterload. So at the base of this pyramid of oxygen delivery are these six important factors. This is a playful way of looking at the key components of oxygen delivery. It's a mnemonic, get to the CHOPA from Arnold Schwarzenegger's Predator. And the CHOPA is contractility, heart rate, hemoglobin, oxygen saturation, preload, and afterload. And preload is mainly defined by the intravascular volume status, afterload mainly by systemic vascular resistance, although that is not the only component of afterload. The nice thing about this acronym is that the first two of those are known as the cardiac factors. The next two form that oxygen content that we talked about, and the last two are vascular factors. And the cardiac and vascular factors together, sometimes you'll see the vascular ones called coupling factors. Those four together are what impact cardiac output. So let's look at those vascular factors first. In order to do so, we look at something called a vascular function curve, which is CVP in the y-axis and cardiac output in the x-axis. And we'll see that as cardiac output increases and the heart is better able to handle that intravascular volume, central venous pressure goes down. Now we see that in a state of hemorrhage where there is less intravascular volume, there is lower central venous pressure and lower cardiac output. The curve is shifted to the left. With transfusion, the curve is shifted to the right with higher CVP and higher cardiac output. And that is how preload affects the vascular function curve. Afterload acts a little differently, where it alters the slope of the curve. So vasodilation will increase your cardiac output at the same central venous pressure because there's less resistance to cardiac output and to ventricular ejection. Conversely, vasoconstriction makes it more difficult for the ventricle to pump against increased resistance, and so at the same central venous pressure, you have lower cardiac output. Now taking it a step further, overlaying the vascular function curves onto cardiac function curves, which are also known as Frank-Starling curves, we see that the intersection of the cardiac and the vascular function curve is a point denoted as the equilibrium point, and that is unique for each patient and each physiology. You'll also notice with these curves that we flipped the axes, so now cardiac output's on the y-axis, CVP is on the x-axis. Now looking again at how preload affects this relationship, preload will shift the vascular function curve to the right, thereby changing the equilibrium point from A to B here. So higher CVP, higher cardiac output. Now, interestingly, afterload not only shifts the vascular function curve slope, as we discussed previously, but it also will shift the cardiac function curve down because with increased resistance or increased afterload, the myocytes are under greater stress, and so there will be reduced contractility of those myocytes. Therefore, increased afterload dramatically decreases your equilibrium point and cardiac output from point A to B. And that is why in the cardiac ICU, we harp a lot on afterload reduction as a means of improving cardiac output. We've talked about the vascular factors that affect cardiac output. Let's move now to the cardiac factors, with the first of those being contractility. So again, we're back to the cardiac function and vascular function curves and their intersection. We see here that with sympathetic stimulation, or an increase in contractility, the equilibrium point shifts from A to D, meaning higher cardiac output for lower central venous pressure, since the heart is able to pump better and to handle that intravascular volume better. How about in condition of heart failure, we see that cardiac function curve shifts down from normal to moderate to serious heart failure, shifting the equilibrium point from A to B to C, which is lower cardiac output at a higher CVP. Unfortunately, in severe heart failure, we also see a state of hypervolemia because the heart is unable to handle that intravascular volume as well, and there can be some third spacing. And in addition to that, there is neurohormonal changes that will increase total body fluid, like the RAS pathway hyperactivation. And so when that happens, we see that the vascular function curve is also shifted now to the right, and the equilibrium point has shifted from C to E. So not only is your cardiac output impaired, but now it's at the expense of a high CVP. And I say at the expense because a high CVP is deleterious to organ perfusion pressure. Organ perfusion pressure is the difference between your arterial and your venous pressure across an organ bed. And when that narrows from decreased function and from high CVP, then that leads to end organ injury like hepatic injury and renal injury, which we see in heart failure. The second cardiac factor contributing to cardiac output is the heart rate. And so what are those chronotropic effects? You would think that with increasing heart rate, since as we said the equation is heart rate times stroke volume, that your cardiac output would go up as your heart rate goes up. The reality is not quite that simple, because with increasing heart rate, your filling time in the ventricle goes down. And so this graph, which is from an experiment in the 60s in an animal model, shows that with increasing heart rate, you have decreased stroke volume, and that is a consistent trend regardless of heart rate increase. The net effect of an increasing heart rate and a downtrending stroke volume on your cardiac output is that you have a U-shaped curve where there is a sweet spot of heart rate where you get maximal cardiac output here on the y-axis, but at too low of a heart rate, even with maximal filling of your ventricle at that low heart rate, you still have a low cardiac output because one piece of the equation, which is the heart rate, is too low. And then with too high of a heart rate, because you have such little filling time, just like in cases of tachycardia or fibrillation, you have impaired cardiac output as a result of that. And so finding that sweet spot of maximal cardiac output related to heart rate is very individualized for each patient and also for each physiology. There are structural differences in the neonatal myocardium that renders it very different in its response to changes in those cardiac factors and vascular factors that go into cardiac output. So neonatal myocytes are very disorganized with sparse myofilaments and decreased mitochondria. There's a high predominance of non-contractile elements like connective tissue disease in the neonatal heart. It handles calcium differently because it has immature sarcoplasmic reticulum, meaning that there's low intracellular calcium stores, and calcium is very important for actin and myosin interaction for myocardial contractility. This is why conditions of hypocalcemia like 22q11 deletion can be very impactful on neonatal myocardium, and why exogenous administration of calcium in the form of either an infusion or a bolus can have significant positive inotropic effects on neonatal myocardium more so than adult myocardium. As for beta adrenergic receptors, they're of similar quantity to adults but decreased number of functional receptors. So there is a limited threshold to how much beta agonism as inotropy can support neonatal myocardium. What this translates to, particularly the high predominance of non-contractile elements, is that the neonatal myocardium is, so to speak, stiff, and it does have stroke volume limitation. We see here that with increasing ventricular end diastolic volume, there's really no significant increase in stroke volume. And that is why neonates are so dependent on heart rate for cardiac output. It's why after neonatal heart surgery, neonates will come out with temporary atrial pacing wires just to support their chronotropy and their heart rate, even if not supporting their inotropy as much. We also see that this neonatal myocardium on the right-hand side here is very sensitive to afterload changes with a more dramatic slope change in that curve with afterload increase. Stroke volume gets severely impaired. And again, more reason why we harp on afterload reduction after neonatal heart surgery for that neonatal myocardium and the importance of chronotropy. We've covered a lot of physiology here. Now that we know this foundation, let's go to the clinical side. What is a normal cardiac output? In resting adults, normal cardiac output is 4 to 6 liters per minute. In pediatrics, we use something called the cardiac index, or CI, and that is cardiac output normalized to body surface area in meters squared. And in pediatrics, a normal cardiac index is 2.5 to 4 liters per minute per meter squared. A neonatal hack is full-term neonates have a body surface area of around 0.25 meters squared. Premature neonates have a body surface area of around 0.2 meters squared. And so multiplying that cardiac output number by 4 for full-term neonates and 5 for premature neonates will give you that cardiac index for those patients. Before we dive into low cardiac output, just clarifying, is low cardiac output the same as low cardiac output, or LCOS? LCOS was first reported in 1975. Around a quarter of children following congenital heart surgery had a low cardiac index, and this was re-examined in 1995 by Gil-Wernovsky, and it was noted that this specific effect following heart surgery happened 6 to 18 hours post-op. So when we say LCOS, we're referring specifically to that post-op, post-cardiac surgery phenomenon. The etiology is multifactorial: inflammation from bypass, myocardial ischemia from cross-clamping the heart and providing that cardioplegia medication that renders the heart electrically and myocardially silent for surgery, surgical manipulation of the myocardium, reperfusion injury post-bypass, and impaired preload or capillary leak. There are pre-op risk factors, including prematurity, genetic differences, pre-op arrhythmias or need for inotropy, as well as pre-op respiratory failure or infection. And the management of LCOS is primarily driven by this PrimaCorb study, which is prophylactic intravenous use of milrinone after cardiac operation in peds. And it showed that high-dose milrinone, specifically above 0.5 mics per kilo per minute, reduced the risk of low cardiac output syndrome compared with placebo, with a relative risk reduction anywhere from 55 to 64%. To talk about low cardiac output, we have to talk about shock, as we mentioned at the start of the talk. It is a state of impaired oxygen delivery, which is including but not limited to impaired cardiac output. What does this mean? In order to understand that, let's look at the different types of shock. Hypovolemic shock is related to decreased preload, which, as we discussed, is a key component of stroke volume and cardiac output. So cardiac output is impaired in hypovolemic shock. It is also impaired in distributive shock, which is related to vasodilation, both on the arterial side, which can actually help cardiac output, as we said, with lowering SVR, but importantly also on the venous side. And so you get venous pooling and third spacing, and therefore there is inefficient handling of that blood in the venous space, hence the need for volume and pressors in those situations. Cardiogenic shock is specifically related to decreased myocardial contractility, either related to congenital heart disease or other non-congenital causes of cardiogenic shock. And here it's important to be reminded that low cardiac output is not just cardiogenic shock, it is any of these types of shock, whether it's related to preload, afterload, or contractility impairment. Obstructive shock tends to be a high afterload state where there is obstruction to either the filling or the outflow of a ventricle, like tamponade or tension pneumothorax. And then the last type of shock, which is where now instead of focusing on the CO part of the oxygen delivery equation, we're focusing on the arterial oxygen content, is dissociative shock. So it is things like carbon monoxide poisoning and methemoglobinemia, where you can have a very normal cardiac output, but still be in shock because you have an inability to appropriately handle oxygen. Either it's not appropriately bound or not appropriately released from hemoglobin. And so that is the exception to the rule where typically shock is a low cardiac output state. Dissociative shock is generally a normal cardiac output state. And here is another way looking at those first four different classifications of shock and how they impact preload, afterload, and contractility. Hypovolemic, again, affecting preload, cardiogenic contractility. Obstructive can affect both preload and afterload, and distributed tends to affect afterload mostly. Highlights of the bedside assessment of cardiac output are that history and physical exam are key to rule low cardiac output in or out. Non-invasive and sometimes invasive hemodynamic monitors and lab tests can support the diagnosis. There are specific cardiac modalities that can estimate or even measure cardiac output, like echo, although that has a lot of assumptions that need to be taken into account, cardiac cath or cardiac MRI, and finally, in instances where circulatory support devices are being used, like ECMO, VADS, or cardiopulmonary bypass, those devices can measure cardiac output, particularly if there's no native output or contribution, since what they're measuring will be the total output. But of course, those are very unique situations that are far from the standard bedside assessment of cardiac output. For the H&P, we're looking from head to toe, and general appearance or neurologic assessment, we're looking at the mental state, whether restless, drowsy, or obtunded, looking at a patient's color, simply put, whether they're pink, blue, or gray, with those being progressively worse, of course, and then a patient's tone, and particularly concerning if somebody's hypotonic, particularly in the face of interventions like pokes. As for vital signs, heart rate is most sensitive for low cardiac output, and it is the physiologic response to a low stroke volume, whether related to preload contractility or afterload. Blood pressure is a late sign of shock when low, and so would not solely rely on that. And pulse oximetry can be helpful in the sense that in mixing lesions, where your systemic saturation is a mixture of your pulmonary vein sat and your systemic vein sat, if your systemic vein sat or SVO2 is low, then that will lower your overall oxygenation. And so in mixing lesions with low cardiac output, we see that the pulse ox is often low. Head, we're looking at the fontanelle. Is it flat? Is it sunken? And similarly, are the eyes normal anterior or are they dry and sunken? From a cardiac standpoint, I'm looking primarily at the periphery, so both upper and lower extremity pulses, centrally and peripherally. We're looking at the cap refill and the peripheral temperature by palpation. And we'll get into non-invasive assessment of that later. Murmurs, in severe cases of heart failure, you can hear a murmur of mitral regurgitation or a gallop. In patients with mixing lesions, specifically if they have a shunt, if you have an absent or a weak shunt murmur, that could be a sign of either low cardiac output or shunt obstruction. And so those are very important. Respiratory, you're looking for dyspnea or thopnea, and that concerning cardiac wheeze or cough when you've ruled out respiratory or infectious causes of illness. And from an abdominal standpoint, you're assessing for signs of abdominal angina, meaning feeding intolerance, nausea, vomiting, pain with feeding, hepatomegaly, and decreased urine output as a marker of end organ injury. For non-invasive monitoring, you're looking at telemetry for heart rate, look at both rate and rhythm, as well as electrical rate versus pulse rate in the case of pulsus alternans, which is a sign of low cardiac output and heart failure. Non-invasively, blood pressure would be by cuff, and pulse oximetry is helpful not only to look at the SAT, but also at the perfusion index, which is a number that can be trended by the pulse oximeter and also by visual inspection of the waveform and the pulse width on that. Toe temperature is the non-invasive corollary to palpating for peripheral temperature. Transcutaneous monitor versus a non-invasive end-tidal CO2 to look at CO2 clearance, and that can be done by nasal cannula depending on the institution you're in. And we in the cardiac ICU love near-infrared spectroscopy, or NIRS, which measures regional saturations, particularly with the goal of getting venous saturations. Typically, we measure them in the cerebral hemispheres, sometimes bilaterally, as is shown in this picture, as well as in the splanchnic circulation, usually overlying the kidney. And the typical expectation is that oxygen consumption by the brain is higher than by the viscera, and so your cerebral NIRS tend to be lower than your renal NIRS or splanchnic NIRS, but both of those are good assessments of your venous oxygen saturation. And this is just going into the technology a little bit of NIRS and how it works. For invasive hemodynamic monitoring, we have arterial lines that could be placed peripherally or centrally, and that looks not just at the systolic, diastolic, and mean arterial pressure, but also the pulse pressure, which is the difference between systolic and diastolic, as well as the pulse rate. A venous line will allow us to look at the central venous pressure, and this is a diagram showing the different components of a CVP waveform, which are beyond the scope of this talk, but are important to understand and interpret when looking at causes of elevated central venous pressure. And then if an endotracheal tube or tracheostomy is present, an invasive end-tidal CO2, which not only is looking at your CO2 clearance and a surrogate of your acid-base balance, but also gives us an idea of pulmonary perfusion as a surrogate marker of cardiac output. And in cases of very low cardiac output, that end-tidal could be low because of impaired pulmonary perfusion. As for labs, I like to think of cardiac, end organ labs, and systemic labs. For cardiac, most importantly, if we have a central venous line, a mixed venous oxygen saturation, which NIRS are a good surrogate for non-invasively, an arterial blood gas with a lactate if an arterial line is present, also could be obtained by an arterial stick, N-terminal pro-BMP if there is a concern for left atrial stretch or left ventricular dilation with cardiac failure that way, or anatroponin if suspicious of an ischemic etiology, although not recommended if not concerned for ischemia. End organs including kidney function and hepatic function, and inflammatory markers, particularly if an infectious etiology of low cardiac output is suspected, like sepsis or septic shock. Now, this shows the different components that go into a mixed venous oxygen saturation. So there's cardiac output at the top left. At the top right and bottom left are the two components of oxygen content, which are hemoglobin and arterial sat. And then finally, at the bottom right is oxygen consumption. And again, states like sepsis and increased work of breathing and pain or anxiety can all increase your oxygen consumption and lower your mixed venous that way. And then this is just showing that in a normally saturated person, 70 to 80% is the normal balance of oxygen supply and demand for a mixed venous. And then there are conditions where there could be decreased tissue extraction, like in hypothermia, but there can also be conditions with increased tissue extraction, which are mainly related to shock and the different types of shock that we've seen, including low cardiac output states. And finally, for both central venous pressure and for mixed venous oxygen saturation, just a reminder that location matters. And so knowing where the catheter tip is that you're getting this sample from, you could see here that a lot of the lower veins, especially the renal veins, will have higher oxygen saturations because the renal parenchyma extract less oxygen as opposed to superior catheters where the jugular vein will have a lower oxygen saturation because the brain extracts more oxygen. The organ that extracts the most oxygen is the heart itself, and so if the catheter is deep in the atrium and the coronary sinus, it may give very low mixed venous readings, like in the 30s and 40s, and that could be measurement error, but I would rule out other causes of low mixed venous before jumping to that. Tying low cardiac output with that LCOS that we talked about, as well as the clinical parameters that we look at in low cardiac output. This is a paper from 2017 showing a low cardiac output syndrome score that was developed and demonstrating that when it's elevated, it's associated with morbidity after congenital heart surgery. And we can glean some things from that score as to what are the key bedside parameters involved in assessing low cardiac output. You see them here. Those are the components of the score. Heart rate, very important. If it's greater than 20% above the post-induction heart rate in the operating room, that is quite indicative of a potential low cardiac output state. Urine output, so thinking about those end organs being low, toe temperature being low, and so remember, body temperature is around 37, room temperature is around 23, so the midpoint between those is 30. So if you're on the colder side, cooler than 30 degrees, then that could be indicative of low cardiac output. A high vasoactive or inotrope requirement, a high volume administration requirement, greater than 30 mils per kilo per day, and then those measurements of oxygen consumption and of lactate generation that we talked about, decreased NIRS as a surrogate for a low mixed venous, and arterial lactate being super important in the assessment for low cardiac output. And this is just the data from that paper, small number of patients, but showing that a peak low cardiac output score greater or equal to 4 and a cumulative greater or equal to 7 was associated with much higher duration of mechanical ventilation, cardiac output and hospital length of stay, and morbidity and unfavorable outcome. Lastly, managing shock. This is a whole talk in of itself, but I thought this diagram is a really good summary of it by the different type, the different etiologies for each of those types, the cardiovascular findings similar to what we talked about previously, and then the hemodynamic support strategy. So for hypovolemic shock, which is primarily a low preload problem, volume expansion plus or minus pressors are key. For cardiogenic shock with impaired contractility, inotropes are the key. And again, inotropes and which one to use is a whole different conversation beyond the scope of this talk. For obstructive shock, really relieving the source of obstruction, for example, with tamponade, with pneumothorax, just relieving the underlying cause as soon as possible. And for distributive shock, like sepsis, where there's both a preload and an afterload problem, rapid volume expansion, pressor use, and of course, treating the underlying cause with antibiotics, for example. And while the last supply focused on increasing supply, so to speak, with volume, with pressors, with relieving obstruction, another key point to treating and managing shock is decreasing oxygen demand using sedation, assisted ventilation, paralysis, and hypothermia if needed. And our last slide here is managing post-op shock after congenital heart surgery or that low cardiac output syndrome. This is a very nice paper showing a systematic approach to post-op management of that low cardiac output syndrome, and it follows a lot of the same framework of increasing supply, meaning oxygen delivery, both the cardiac output components that we discussed and the oxygen content, decreasing metabolic demand, and finally monitoring for recovery, ruling out residual heart defects, and in the most severe cases, considering mechanical circulatory support to support the patient through recovery. Thank you very much for your time.